Okay, good afternoon and welcome to the GAMMAPOD Stereotactic Partial Breast Irradiation webinar. My name is Steve Rubenstein. Today's presenter is going to be Dr. Asal Rahimi. Dr. Rahimi is an associate professor and the chief of breast radiation at UT Southwestern Medical Center in Dallas, Texas. UT Southwestern was the second site to go clinical with GAMMAPOD. And so now I'm going to turn it over to Dr. Rahimi, who will lead today's presentation.
Hi, thanks for having me. So today we're going to talk about GAMMAPOD and stereotactic partial breast radiation. Here's our disclosures. So first we're going to start off by going over a little bit of background and then going over a little bit of initial clinical experiences, overview of workflow and the technology, and then several case studies and some clinical outcomes. So as you guys are probably all aware, back several months ago or last year, NSABP39 and RAPID trial presented their data as far as local recurrence goes. And these were two large trials that were comparing whole breast irradiation to partial breast irradiation. And what they found with NSABP39 is that there was a 0.7% difference in ipsilateral breast tumor control or recurrence. And that actually was a significant difference, and the RAPID trial was only 0.2%. Now, many would argue that 0.7% really isn't that much of a clinical difference, but it did reach significance. The cosmetic data was also reported in these studies. So specifically in the RAPID trial, when they compared APBI to whole breast irradiation and the nurses rated cosmesis, you can see here in the orange at the different time points of 3, 5, and 7 years, there tended to be a high proportion of patients that had cosmetic ratings of fair or poor versus the whole breast irradiation arm. As far as the patient cosmetic rating, the same held true. It was 31% fair or poor at 7 years in the partial breast irradiation arm. So this was at 7 years, which I think was kind of surprising to a lot of us. NSABP39 also reported this in abstract form at ASTRO. And what you can also see here is that the red and the blue are the fair and the poor. So there was a substantial amount of fair or poor cosmesis using 3D conformal BID regimens with very large margins. There was about a 20 to 30% rate of poor or fair cosmetic results on that study. So how can we improve upon cosmetic outcomes? Perhaps changing the dose or the fractionation. Instead of doing BID, maybe doing a Q daily or even doing every other day. Other ideas could be changing the volume of the tissue targeted in those trials that we just mentioned. The total expansion with CTV and PTV was anywhere from 2 to 2.5 centimeters. So maybe if we reduce our PTV margins down substantially, we could irradiate less breast tissue and have better cosmetic outcomes. Maybe even the CTV margin doesn't need to be 1 centimeter. And then using our technology really to kind of help reduce these margins, maybe doing daily image guidance or adaptive planning. So here is one example of using the technology that we have on the GAMMAPOD and really showing a difference in kind of how much breast tissue can be irradiated. So here in the right panel, we have a patient with a prone breast treatment, and this would be for the boost portion. And as you can see that using just kind of a linear accelerator and a prone breast board, this cavity really kind of just elongates and is very long, and you can see a lot of dose spillage kind of going throughout the entire breast. In comparison, we have a prone boost setup here on the GAMMAPOD, and you really do see a lot less breast tissue is spared, and you have much quicker dose fall off, and it actually changes the shape of the breast because it's in a vacuum system. So some of our initial clinical experiences were at University of Maryland because that is where it was discovered or where this technology was made. And so once this technology was made, the first trial was a trial that was necessary per the FDA, and they did a boost trial back in 2015 to 2017. In December of 2017, the GAMMAPOD received FDA clearance, and then University of Maryland resumed patient treatment in November of 2018. And then to date, they have treated a total of 243 treatment deliveries. UT Southwestern started treating basically in March of 2019. We had, after the FDA clearance, we still had to get some state approvals. So it took us about a year and 3 months after the initial FDA approval to get going. And we also have had about 200 treatment deliveries since March of 2019. So this technology, like I said, was invented at the University of Maryland. And it is a system that is designed to precisely target breast cancer tumors and solely breast cancer tumors. It uses cobalt sources, which are source right here where I don't know if you guys can see the arrow. And this is the table, and the table can actually also move as well. And this table will move from the horizontal position to the vertical position to load the patients. So back in 2006, the GAMMAPOD was patented by Dr. Rahimi and former Chief of Physics, Dr. Cedric Yeo. And then in 2007, they received a $3.5 million NIH grant for development of the GAMMAPOD system. And then the first clinical trial was launched in 2015. And then, as we mentioned, it was FDA approved, but with FDA clearance in 2018. So what is our workflow on the GAMMAPOD? So there are various sizes of breast cups and shapes for that matter. And so the first thing that would happen is we would fit the patient to this breast cup. There is an inner cup and an outer cup, and it's attached to a vacuum system. There's also a stereotactic. There's a wire here that helps with the stereotactic nature of the treatments. And so first we do the cup fitting. Then we have a separate patient loader that can kind of attach on to the end of a CT simulator and be taken back to the side of the room when you're done using it. But it takes patients from the vertical position to the prone position, and then there's holes within the table so that the breast cup can go into those holes and latch in. Then the patients would get scanned with the breast cup and the vacuum seal on. And then during that time, then we would do real life treatment planning, contouring, and then optimizing the plan similar to what you would do with a gamma knife treatment. And this would need to be done for each treatment. And then after that, after that whole process, then you would then bring the patient onto the actual GAMMAPOD unit, load the patient, and deliver the treatment. So here are the breast cups. There are many more different sizes, but here we have the small, medium, and large, so you can kind of get a sense of the different shapes and sizes that are available. But as I said, there's many more of these. And then depending on which cup size you choose, there's a different inner cup that would then basically be attached to these cups right here. And then there is an outer flange which connects to that whole system and then helps kind of tape the cup onto the system with medical adhesive. And then sometimes if there is a gap within the breast cup itself, in order to refrain from having too much suction on the breast, we could place a bolus to kind of fill those gaps and hopefully make the patient a little bit more comfortable as far as the vacuum seal. So basically, as far as the cup fitting goes, we would want to have less than 1 centimeter gaps between the actual breast tissue and the edge of the inner cup. And you can kind of fill those volume defects with silicone. And really, you basically just place it on to the breast. And then there are pegs that would then lock into the actual GAMMAPOD table. So you need to make sure that those pegs are in the correct direction before you put the flange with the medical adhesive onto the patient. So this is a picture of our vacuum. So you can, this picture doesn't actually show, but there is actually a line here that then connects to the breast cup system. But this vacuum, you basically would just turn it on, then the vacuum suction should have negative pressure anywhere between 140 to 150 millimeters of mercury. This is very similar to a breast pump used for breastfeeding. So it's not it's not uncomfortable. And then basically you would want to make sure that this seal is not lost. And if the negative pressure reduces during treatment, then you know the seal has been broken or lost. And so you do want to make sure that you maintain this during the entire course, from the time that the CT scan is done till the time the treatment is delivered. So after the CT images are obtained, we would review those, and then we would transfer them to basically our system where we would want to contour on. At UT Southwestern, we use Eclipse, and then we transfer them over to the GAMMAPOD treatment planning system, but you could directly take them to the GAMMAPOD treatment planning system. And then basically the patient would be waiting for you until the actual treatment is, the plan is contoured and the plan is optimized, and then you would transfer the patient from whatever room that they're waiting in onto the actual GAMMAPOD machine, and then treat them in the prone position. So once you actually transfer the images, the CT images, into the treatment planning system, there's a rigid registration that would happen, and that would kind of determine the inner and outer cup sizes. And then the treatment system planning is actually pretty quick. It's less than 6 minutes, but you can also optimize based on whatever organs at risk you're concerned with, like skin or chest wall. And then basically we would approve our plan, and then we can transfer them into the treatment planning system to the treatment console. So here's an example of kind of like what the setup looks like on CT scan. So we have our cavity right here, and then you can see here, this is the outer cup. Those are the wires that I was pointing out before. And then here is the inner cup. You can see there's not really much gap in between the inner cup and the breast. And then this is the table, and you can see a little bit of artifact right here. And then this is an example of a plan that was, this was just an example plan to 12 gray. But what's important here, I think, is to appreciate this quick dose fall off that you have. This purple is 3.4 gray, and the red right here is 95% of 11.4 gray. So there's a very quick dose fall off once you get your planning. So the clinic workflow between University of Maryland and UT Southwestern is a little bit different, but that's because we had a little bit of a different setup. So I'm just going to kind of go over that quickly so that people can kind of understand that. So at University of Maryland, they have their GAMMAPOD unit on a separate floor as their CT simulator. So as a result of that, patients will need to walk from their CT simulator to the GAMMAPOD unit, and they need to do that with suction on. Usually when this occurs, the physician is contouring, and then they are starting to optimize the plan, so the patient will arrive to the GAMMAPOD unit once they're almost done optimizing or in the middle of optimizing their plan. So I would say that for both institutions, this kind of is the same. The cup fitting, CT scanning, treatment planning, treatment delivery. And here you can see kind of on average how much time it takes for each of these steps. About 5 to 10 minutes for the cup fitting, 5 to 10 minutes for the CT scanning, 15 to 20 minutes for the treatment planning, and then 15 to 25 minutes for the treatment delivery. So at UT Southwestern, it's a little bit different because our CT simulator is located right next door to the GAMMAPOD unit. So we would do the cup fitting, CT scanning as previously described, and then we would basically transfer our CT scan images into Eclipse, and then we export them into the GAMMAPOD treatment planning software for the actual planning and optimization purposes. And then after we're done with that, our physicists have actually developed an in-house additional QA, which is run on each plan after each plan is approved and prior to delivery for each patient. So this adds about an additional 10 to 15 minutes, which is mainly from data transfer from the GAMMAPOD treatment planning software to the QA server. And then the QA calculation and document generation takes about 15 minutes. So our process is a little bit longer, but it's because we do this additional QA prior to each fraction that we deliver. This is a picture of our setup. So the GAMMAPOD is basically right in here. You can't see it through those doors. And then over here in the corner, we have a CT on rails. And then right across, we have another CT simulator. And then you can see we store the patient loader right here. So we can either use it on the CT arrow if we're doing the CT simulation there, or right across the hall. And here you can see kind of the architecture of the way that our GAMMAPOD is set up. So we'll move on to a case study. So we have a GAMMAPOD consortium, which basically is between University of Maryland and UT Southwestern. And then we have several other institutions that will be onboarding shortly, but they are also part of our consortium. And we run clinical trials through this consortium. So this patient was on one of our accelerated partial breast irradiation studies, which is a 5-fraction study delivered every other day, where we do 40 gray and 5 fractions. So this was a 76-year-old female. She was found to have microcalcifications in the 1 o'clock portion of the left breast that was shown to be DCIS grade 3 ER/PR positive. She had a partial mastectomy, and the DCIS was 1.8 centimeters with negative margins. She was given different options for treatment, but decided to move forward with partial breast. So she was enrolled onto our study. So here you can see an example of her plan. I know that this is a little bit difficult to see, but so she received 8 gray, which is in the red line here, 8 gray to the CTV, and then we do 6 gray to the PTV. So a total of 30 gray to the PTV and 40 gray to the CTV. This very, very kind of darkish purple line is 3 gray, if I can read that correctly. So you can see here's some more examples of some partial breast irradiation plans. This is an irregularly shaped cavity, but you can see that the GAMMAPOD does a really good job of actually still kind of maintaining that irregular shape in the planning. This is more of a regular kind of ovoid cavity, and that also, it does a good job with that also. And you can see how quickly the dose is falling off. So another study that we have in our consortium is a boost study. And that is basically doing our boost in 8 gray times 1 fraction up front, and then proceeding on with the whole breast irradiation. And the boost is on the GAMMAPOD. So this was a 68-year-old female. She was found to have a new left breast mass at 11 o'clock. And this was basically a triple negative breast cancer. She had a 15 millimeter IDC and negative lymph nodes. She received adjuvant chemo, and then she received 8 gray times 1 on her boost, and then whole breast irradiation. So her case was the whole breast irradiation was delivered with a prone technique, and you can see here with the prone techniques, I think many of us have seen this that treat prone breast, the cavity just gets completely elongated. So really the only way to treat this is to come in and irradiate a very large volume of her breast by the time you get beams into this. So her plan was actually pretty nice because, again, the tissue was compressed, but we were able, or the physician treating this was able to really kind of just hone in onto that and not treat such a large portion of the breast. So this is another case study of treating an intact tumor. So this is a 79-year-old female with metastatic angiosarcoma that was on chemotherapy and found to have a new mass in the contralateral breast. So she was prescribed 40 gray and 5 fractions with a CTV of 1 centimeter and a PTV of 0.3 centimeters delivered every other day, similar to the protocol we have. And as you can see here, so fraction 1, fraction 2, looks like fraction 3, and then fraction 4, you can see that this tumor is actually getting smaller as we're treating it. The GTV on day 1 was 5.8 cc's, and on fraction 5, it was down to 0.75 cc. So there was really a nice reduction in size using this approach. So what are some of the side effects that we can see with this technology? So most of it is related to the suction, and some people can get these suction blisters. Risk factors for developing these are patients that have diabetes or smokers that just have really thin skin, like elderly women, or sometimes if you use the bolus, it can cause more of a blister. It's an independent risk factor for each fraction. So if the patient develops it on the first fraction, they're more likely to develop it on subsequent fractions, and also the longer time that you have the breast cup on, the higher the risk of developing one of these blisters are. Some people can get a contact dermatitis from the adhesive on the pink flange, and that can just be treated with topical steroids. So University of Maryland submitted their first 13 patients to the San Antonio Breast Cancer Symposium back in 2019 using 6th grade times 5. And you can see here that they had very few they didn't have any grade 2 or higher toxicity, and there was few patients that had side effects using this approach. So what is it from the patient experience? Patients love having the short course of therapy. The immobilization does not seem to be very painful, but most of them will complain of neck discomfort, especially when they are getting treated for the 15 or 20 minutes on the table. They can sometimes get some neck discomfort, especially women that have arthritic problems. The suction blisters, if they happen, they don't tend to be painful, but they can just look like really bad blisters, but they usually will, they will heal quickly if they're appropriately managed. So we are also looking at cosmesis outcomes on our 5-fraction adjuvant stereotactic partial breast protocol. So far, so good as far as those results. We have not reported our phase 2 study yet, though. And then University of Maryland had one patient that was treated off protocol that did have a breast recurrence, but also had a lot of extensive delays after diagnosis and treatment. So currently, as far as efficiency and workflow, what we do at UT Southwestern is, because some of these patients will get 5 treatments, we usually have kind of like a doc of the day on the GAMMAPOD unit. So we rotate the days that the GAMMAPOD is being covered, and then different physicians will deliver the different treatments on those subsequent days. Every site is going to have kind of a little bit of a different workflow depending on what their setup is and patient populations and clinic schedules. But there is a steep learning curve. Most of it is related to the cup placement, learning the new treatment planning software, and then also learning patient selection and which patients are really good candidates for GAMMAPOD. So I think that with the GAMMAPOD, how this has affected the era of COVID, I think it's been very positively received by patients, because they can continue to wear their masks, and then they can try to get these shortened courses of radiation, which means less hospital visits and less potential for COVID exposures. So I think that the vision that we have on the GAMMAPOD is that we would like to find a group of early stage breast cancer patients where we can treat with radiation therapy alone, and have no surgery. And this could be like a non-invasive technique, continue to improve the convenience and the cost of treatment, and decreasing the dose of radiation to normal breast tissue over some of the other technology, all while improving the quality of life and improving healthcare costs for our patients. So here we go. So what are some of the opportunities for the GAMMAPOD? We have a consortium in which we have several ongoing clinical trials and multiple sites, which we'll go over those sites shortly. And basically, one of our biggest interests is doing definitive radiation for early stage breast cancer. So preliminary work that was done from University of Maryland using a BID approach showed a response rate of 15% using kind of just the regular adjuvant partial breast irradiation doses. There has been several preliminary studies that have also showed good responses with preoperative radiation. The PBI study did 40 gray in 10 fractions or 30 gray in 5 fractions and had a 20% path near CR response at 6 weeks. Duke did a pre-op trial, but only had surgery within 10 days. And then there was an ablative trial, which was in the Netherlands, which showed a path CR at 42% with 20 gray at 6 months, or 48% if they postponed it to 8 months and did the surgery at 8 months instead. So there is some preliminary data that is looking very enticing. Some of the current portfolio that we have on our GAMMAPOD consortium is our 5-fraction adjuvant PBI trial, where we're the PI on at UT Southwestern, and then the GAMMAPOD registry and quality of life nomogram, which is the BOOST study, the 8 gray times 1, which University of Maryland is the PI on, and UT Southwestern is a subsite on that. And then we have both University of Maryland and UT Southwestern have 2 independent preoperative breast radiation trials. So, you know, I think the consortium is great because it allows us to do these clinical trials and do them in a much more quicker, efficient manner and answer our questions a lot faster. So currently, University of Maryland and UT Southwesterns are the only ones that are treating patients, but Allegheny in Pittsburgh is under installation, Ottawa Hospital in Canada, and then a site in Udine, Italy, and then Shandong Cancer Hospital Center in China are also currently under installation. So there are 4 units that will be onboarding here shortly.